بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. Basic Coronary Angiography Part 1, Anatomy and Basic Views. This is a pre-test. Everybody has a pre-test paper. Look at the view, and there is a question after that. What is only which view is this? Okay. Simple question. No. Hello? What is the view? Okay, next. And please specify cranial, beside cranial or caudal. Okay. The previous was not cranial or caudal, okay? Okay. Yes? Next. First, we will start for who does not know about the coronary anatomy, just in brief. This is the heart have two surfaces: sternocostal surface and diaphragmatic surface. Sternocostal surface is mostly the anterior surface. Diaphragmatic surface is the inferior surface, inferior and posterior surface. This is the pulmonary artery, okay, the most anterior vessel, okay, and this is the aorta, posterior to the pulmonary artery, okay. This is the LV, this is the RV, and this is the interventricular septum, okay, or sulcus from the outside, okay, separating the LV from the RV. This is RA and right atrial appendage. This is appendage, right atrial appendage, and behind you can see it. It is behind the LV. It is the LA. Okay. This is this interventricular septum anteriorly and it posteriorly on the inferior surface, and this is the atrium between the atrium and ventricle, atrioventricular sulcus. Okay, here and here. Okay, this is the for the pulmonary veins draining into the left atrium. It's clear? This is the SVC. So SVC, aorta, pulmonary, okay, and this is the pulmonary veins, and this is LV, RV, separated by the interventricular sulcus, and this is RA, RV, separated by the right atrioventricular sulcus. Okay, as we see here, the aorta, from the aorta, two vessels. Okay, what is in red is the arteries, oxygenated blood. What's in blue, it's the veins. We will discuss only the arteries now. Okay, so this is from the left side, this is the left main, divided into two branches: LAD, okay, descending into the interventricular sulcus, okay, and LCX going to the left and to the back, then through the left atrioventricular sulcus. This is the atrium, this is the ventricle, and this is the atrioventricular sulcus. Okay. On the opposite side, this is the RCA passing through the atrioventricular sulcus, but the right side, right atrioventricular sulcus, okay, and going to the back to the atrioventricular sulcus. For the RCA, before it going to the back, give the acute marginal branch, okay, and then divide in the back, okay. What's the problem? Sorry. We press on end. Okay. This is the diaphragmatic surface or the inferior surface. This is the LA, okay. So it's the LV. This is the RA. This is the RV. This is the posterior interventricular sulcus, and this is the atrioventricular sulcus, right and left. So here it's the continuation of the LCX, and here is the continuation of the RCA. Yes, it's clear. The RCA in 85% of patients divided into two branches, PDA and PL, posterolateral. Posterolateral anastomosis was the continuation of the LCX, while PDA will go into the interventricular sulcus to anastomose with the LAD, okay, from anterior interventricular with the posterior interventricular sulcus to anastomose with each other. It's clear? So if you imagine, it's just a two circuits. Horizontal circuit, okay, more or less horizontal, which is the atrioventricular sulcus, okay, containing here the LCX from anterior to posterior, and here the RCA to anastomose, which is other posteriorly. The site of anastomosis is called the crux, okay, and perpendicular to it, can you give me your hand? Okay. This is the atrioventricular sulcus, okay, and it is not horizontal, or it could be to some extent, and this is the interventricular sulcus, okay. So this is the LAD, left anterior descending, this is the posterior descending artery, and anastomosis each other. And this plane is the LCX, left circumference, and the right coronary, and anastomosis each other. It's clear? So it is two perpendicular planes, okay. Let's go. To read any coronary angiography or angiographic view, okay, we should know these rules. The first, we should be oriented to the views. It's ROO, LOO, AP, or lateral, okay. Don't overread, okay, as anything including X-ray, okay. Use non-cardiac cues, okay, as the spine and the sternum, okay, and diaphragm, and know what is normal is, so you will know what is abnormal. Get oriented. First, how we know it's RAO or LOO? We will ask ourselves two questions. Where are the ribs and where are the spine? Where is the spine? Okay, so where are the ribs here? This is this, okay? This is the ribs. Where is the spine? Can you see it? If you can't, this is the shaft of the castor. The shaft of the castor is ascending into the aorta, okay? So it is here is the spine, not here, okay? So it is the back, posterior, and this is the spine, and this is the ribs, okay? Once the spines on the left side of the image or the right side of the patient, okay, as X-ray, here is the liver, okay? So this is RAO. A simple method, okay, is method of your hand. If you can you see? What is the remote? Okay, that's good. So the ribs, the direction of the ribs, you can you want to catch the spine, okay? You will catch it by your right hand or left hand? Your right hand, okay? If it's put your left hand, you can't catch it, okay? It's malalignment, okay? Okay? So it's by your right hand, so it's RAO, okay? No, it's malalignment. It's okay. Yes. Okay. So if you can catch the spine by your right hand, so it's RAO. If you can catch the spine is here. By your left hand, it's LAO. So where are the ribs and spine? So this is RAO, as a spine is here, and you can, if you can't see it, you can notify it from the caster. It's arising in the ascending aorta, while here is the spine and this is the ribs, the direction of the ribs. So this is LAO, as you can catch the spine and the caster through your left hand. This is the direction of your right hand. This is the most important slide, okay? This is an LV angiogram, okay? And so the first thing you want to know is you should know the walls. Once you know the wall, okay, so you can know what's the artery on it, what's the graft on it, what's the anomalous on it, okay? That's simple. So here, if you know in the echo, it is resembling the parasternal long axis, okay? So this will be the LV, okay, the anterior, apex and inferior, okay? And here will be the left atria. If there is a mitral regurg, so there will be going this there, okay? So if this is with contrast, if we remove the contrast, okay, and we didn't routinely do LV angiogram, so just imagine if the catheter is here, so, and it is RAO view, so what's this wall? It's anterior. Here anterolateral, here apex. So what is the vessel is coming here? It's the LAD. It's clear? And what is this wall? Inferior, posterior, and this is the atrioventricular sulcus. Okay? So the LCX will come here. Okay? It's clear or not? So, as we said, this is the LA, this is the LV, this is the anterior wall, okay, and this is the apex, this is the inferior wall, okay, so, and this is the atrioventricular sulcus, and this is the interventricular sulcus. So the anterior wall, the LAD will go here. If there is an graft and it's coming in the LAO, in the RAO to this, to the anterior wall, so it will be the lima or venous graft according to the view, okay, to the LAD, okay, and this is the atrioventricular sulcus, okay, so it is the LCX. If there is a graft here, will be to OM, okay. It's clear. This is the OMs. First, second, and third. It's number different from 1 to 1, okay, and it's the LCX gives these OMs obtuse marginal before it turns back to communicate with the RCA, the posterolateral branch of the RCA. It's clear or not? This is LAO. The LAO, what's this view resembling in the echo? Short axis, just on. So, in the short axis, the mnemonic is SALI. This is the septum, this is the anterior, this is the lateral, and this is the inferior. Where is the RV? Here. Okay? as a short axis. So if you have VSD or VSR, so what will be the direction of the dye from here to here? Yes, it's clear. So you can, even congenital, you can read, no problem. Once you got the anatomy and the orientation, you oriented the view and where is the walls, so you will know what is the normal, what the arteries are going to, what the graft, where the graft are going to, okay, where if there is any shunt, if there is any fistula, you will know everything. Okay, here, this is aorta. In the aorta, okay, there is right, this is will be the left coronary cusp, and this will be the left and the right, okay, while here this will be anterior and posterior, okay, this is anterior and this is posterior, the LA. It's clear? Anterior, it's the apex and the sternum, and this is the posterior, while here it is right and left, okay. So it is Sally, septum, anterior, lateral, inferior. So where is the position of the LAD you will expect? Here or here? Here on the septum. The LAD is in the interventricular sulcus and with the perforated septal perforators invaded into the septum and the PDA from the inferior surface, okay, to supply the septum. While what will be on the lateral wall? LCX. If the LCX is dominant, you expecting to give a PDA where? Here, to supply the inferior. If not dominant, it will stop here. It's clear? Where will be the RCA? If you inject the RCA in this view in the LAO, what will you expect the RCA? It will be here. Yes? And if it's dominant, will give the inferior. It's clear? So it is Sally, septum, anterior, lateral, inferior. This is demonstration, okay? As we said, this is left domain, and this is LAO view, this is the aorta. So this is the Sally, this is septum, anterior, lateral, inferior. Who will supply the septum? It's the LAD. This is the LCX. Okay. Where is the atrioventricular sulcus in this graph? It is a circular. Okay. It is a circular. The sulcus is a circular, lateral. Okay. And here, with the RV, will be here. So the RCA will come here, and this was with the LAD, the LCX. While the interventricular septum or sulcus will be perpendicular to you. Okay, so when you take a cut section, you will not see, you will see this as circle or cut section. Okay, while this is the cut section, and this is will be the LV, RV, okay, will be here. Okay, it's clear or not? So this is the RCA. As we said, it is the right atrioventricular sulcus, and from behind will be, this is the continuation of the RCA, as you see, to give PDA, okay, and PL, what's in the faint color, okay, this is from behind. This is the LCX, give OM, and then go to the back and into the atrioventricular sulcus, okay, and anastomosis with the PL, posterolateral branch, which is the continuation of the RCA. Clear or not, Dr. Marwan? Okay. Revision. This is RAO, so this will be anterior, posterior for the aorta. Okay. What's the importance of this? Will be important in the anomalous. Okay, to know what's the course of the artery, of the anomalous artery. It's malignant because this is aorta. Where you suspect the pulmonary will be? Anterior to the aorta, so will be here. As we said in first, that pulmonary artery is the most anterior vessel. This is posterior to it is the aorta. Yes? So the pulmonary will be here. So if you see a blood supply, a vessel coming outside the border of the heart going to here, so it will be, what would be? It's a fistula. It is coronary pulmonary fistula. Okay? So once you know the anatomy, you will get an abnormality. It's clear? So this anterior, posterior. Okay, from this you will know why I emphasize on this point, because you will know the course of the anomalous artery. It is interarterial course, it's malignant course, or the artery, it's anomalous but retro aortic or benign course. Okay, so there no intervention is needed. Okay, it's clear. Right. If you see this is RAO. You know RAO from the direction of the ribs, and this is the spine here. You can put your right hand. So this is the RAO. What's the RAO? What is the wall? Yes. Okay. This is the ribs. Okay. It's more clearer here on the. So this is the ribs. Your right hand here and the spine here. So it's RAO. What's the walls? Anterior. Okay. Apex and inferior. In brief. So, and here atrioventricular groove also. So yes, and here will be the left atrium. Yeah. So what's the vessel come to the anterior? LAD. What's the vessel come to the atrioventricular groove? Atrioventricular groove LCX. If it's dominant, will supply, giving PDA and supplies of inferior. It's so simple. Okay. If you want the RCA, what you will expect the RCA here? Will be on the same level. This is atrioventricular groove, but will go backward, okay, and will appear here. Okay? مع LCX, yes, but it from behind. Okay? We will get the left system alone, then the right system alone, and then both simultaneously. Okay? So, what is this view? Is the LAO. How we know that the LAO? Where you expect that the spine will be? Here or here? Oh. Here or here? Here. Yes. Okay. And the direction of the ribs will be here. Okay? My left hand. Okay? So what's the walls? Sally. Septum, anterior, lateral, inferior. Okay? So what's the vessel going to the septum? Yes. What's the going to the lateral? LCX. If the circle is dominant, will give PDA to the what? Inferior. Okay. Where here? Where is you expect the RV? It's the short axis of the heart. Okay? Short axis. Where is the RV in the short axis? Here. Yes? So the RV will be here. Okay? And this will be the atrioventricular sulcus, left and right. So the RC will be here, If it is dominant, we'll give PDA. If not dominant, we'll stop here. It's clear? Clear, alhamdulillah. This slide, you will find it in any coronary angiographic lecture. Okay? This is illustrate why I said before. What's this? The two planes. This circle will be what? Atrioventricular. And this is interventricular. This is the atria. What this is the view? It is RAO. Okay? So here the LV, here the LA, and here the atrioventricular sulcus, and here the interventricular sulcus. So the atrioventricular sulcus. Okay? What will you expect is this? If it is RAO, what's the walls? Anterior, apex, inferior. So what will supply the anterior? LAV. What will and this is the interventricular sulcus. What this vessel will be? LCX. Yes. Okay. And if the LCX is dominant, what will give? PDA will continue here and give the PDA in field. Okay, supplying the field. What is only 10%. Okay, and what will be this? RCA in the right atrioventricular sulcus. Okay, and most of the time it is dominant, so will give PDA and PL to anastomosis with the continuation of the experience. It's clear? Okay? Here, what's this? LEO, so it's the short axis. What you expect from the short axis? The two planes, or this is the horizontal plane of atrioventricular plane. Okay? And this is the vertical, the interventricular plane. Okay? So, what will be this? The walls first. Sally, septum, anterior, Sally of the LV. Septum, anterior, lateral, inferior. Okay? So, septum, what will supply the septum? LV. What will supply the lateral? LCX. What will supply the inferior if left dominant? LCX will give PDA here. Okay? This is inferior. Where will be the RV? Will be here. Okay? So, and this is the right atrioventricular groove. Yes? What will supply, what will come here? RCA. Okay? And then will divide into terminal branches, PDA and PL. PDA will supply the inferior. PL will communicate with the LCX. Okay? Clear? Up. Clear or not? If not clear, he will be sad. So first know the view, as we said, it's RAO, LAO, okay? And how you know that? So then know the wall, okay? So will you once you know the wall, you will know what will supply it, what the artery will supply it. So after you know the arteries. This is about the dominance. What's this view on the left? It is RAO. Okay, RAO. No, it's not RAO. Here is the spine. Okay, if you not see, and this is the rib. Yes, it's LAO. Perfect. So once this LAO, so what's the walls? And this is the walls of the LV. Septum, anterior, lateral, inferior, cell. Okay? And so where is this? This is RV. Okay? This is RCA, yes. So this is RCA giving what? Giving PDA or not? Because the inferior is here. Septum, anterior, lateral, inferior. So it's giving PDA. Once it's giving PDA, so it is what? I'd say no, it's 85%. What's this view? If you can't see the ribs, search for the shaft of the calf. What's the shaft of the calf? Ascending in which vessel? In the aorta. The aorta is backward, so the spine will be here. So it is the spine. So it's what's this view? Yes, it's LAO. What? This is the wire of the cabbage in the sternum. Okay, and this is okay. It's not cabbage because this is what? Valve. Okay. Valve replacement. So what's this view? LAO, as you said. Bro. So what's the walls? This septum, anterior, lateral, inferior. Okay. Yes. So this is what we call this view. It's a spider view. It's like spider. Okay. What will supply the septum? The LAD. This is the left main and this is the LAD. Okay. But we are looking from below because this is LA caudal. Okay. From below. So the LAD will see as a line. Okay. In front will be it's rising and descending to the supply the septum. And what this is? The lateral wall. So the lateral wall, what will supply? Supplied by the circ. Yes. This wall what? Sally. Septum anterior, lateral, inferior. Inferior. Supplied by what, which vessel? LCX. PDA from the LCX, so it is left dominant. The remaining 5% will be co-dominant. Okay? It's clear? What's this view? Yes, it's REO. Straight. Okay. Cranial or caudal? How will we differentiate cranial from caudal? By the diaphragm. If it's cranial, okay, so I will see the diaphragm. If the camera or imaging intensifier is taking the image from caudal, so we will see the proximal vessels, but not see the diaphragm. Okay. If I am taking the image, okay, from cranial, so I will see the distal, mid and distal segments of the vessel and see the diaphragm. It's clear? So this is caudal or cranial. This is diaphragm. Okay? So it's cranial. So it is. This is the diaphragm. So it is RAO cranial. The RAO cranial. No difference for us. Cranial from caudal. It's the same walls. Okay? It's just different view to see which vessels will appear more. Okay? If it's cranial, you can see that, and you can comment for both the mid and distal segments. While if this is caudal, the proximal segment it's appear well, but the mid and distal are foreshortened. Okay? You can't comment on this vessel. It's clear? So what's this RAO? Cranial, as you say. So what's the walls? What are the walls? Yes, Sally, septum, anterior, sorry, not Sally, anterior, apex, inferior. Yes? And this is the atrioventricular sulcus. Okay? So what will supply the anterior? LAD. And what's this? This is the diagonal. Okay? The LAD give, what's the branches of the LAD? Septal perforators and diagonals. Septal perforators, why it's from, why they are named septal perforators? Because they perforate into the septum to supply it. Okay, how you know them? They are descending in a Y-shaped manner. Okay, when they are big enough, you can see them. Okay, diagonals. The diagonals. If this is the heart, okay, and this is the RV, and this is the LAD, and this is the interventricular septum. The LAD is descending in the interventricular septum, okay, and giving septal perforators to supply the septum. And the PDA also giving septal perforators to supply the septum from backward and inferior, okay? So what the vessels that will supply the anterior wall itself? The diagonals. So we'll give diagonal branches, okay? The number is varying from person to person, okay? To supply the anterior wall itself, okay? It's clear? So this is diagonals. Where is the circ? This is the circ, okay? This is the circ. It's dominant or not dominant? This is. It's not it's very black. It's not dominant. Okay, not giving. This is the inferior. It's not giving PDA. Okay. So what's this view? Yes, RAO. Where is the shaft? This is the shaft. This is the spine. This is the aorta. Okay. So the ribs will be directed in this manner, in this direction, and you will catch the spine by putting your hand in this direction, your right hand. So this is RAO. Caudal or cranial? Can you see diaphragm? No, no diaphragm. So it's caudal. What's the walls? Anterior, apex, inferior, and this is circle of atrioventricular groove. Okay. So what will supply the anterior? LAD, yes, and what this will be? LCX. Okay, and the inferior it's not supplied by the PDA, so it is not dominant. What's this view? This is the shaft, so this is the spine, so this is the aorta. So the direction of the ribs will be in this direction, so you will catch the ribs, the spine and the calf through putting your left hand. Okay, so this is LAO. Okay, LAO cranial or caudal? This is diaphragm. Okay, so it's cranial. So what's the walls? What are the walls? Sally, septum, anterior, lateral, inferior. So this is the septum. So what's this vessel? Septum. LAD. Okay. Lateral. LCX. It's not dominant because it's not giving the inferior. And this is the left main. Okay. What's this view? Shaft. So this is the spine, the aorta. So the direction of the ribs will be Z. So what is the view? It's LAO. Caudal or cranial? Caudal, because no diaphragm. Yes. So this is a spider view. Okay? Septum, septum, anterior, lateral, inferior. So what's this vessel? LAD. What's this vessel? LCX. Okay? And as you see, from this view, I can see the left main and assess it well. Okay? And I can see the bifurcation into the LAD and LCX. And this is one of the best views that used for engagement of the wires and assessment of the left main disease and ostial and proximal LAD and LCX. Okay? Because as we saw, as we said before, that the caudal view will assess which segments, proximal or distal? Proximal. Okay? While the cranial views will assess which segments, mid and distal. Here, what you are thinking about the LAD? It's a very small. It's not small, but it is shortened because are you saying from behind and below? Okay, from caudal. But here it is straightened more or less, and you can see it's Mid and distal segment. Okay, which one is the LAD? This is a question. Dr. Marwan will answer. And Dr. Ayman will answer. Yes. It is A or B? This vessel or okay, this or this or this? Okay. You show the film and said to me what's which is LED? This or this or this? This? Yes. Why not this? And this going to the apex also. Because there is what we call the kissing sign. What's the kissing sign? The all vessels. Okay. This is what's this view? Yes, it's REO view. Okay. AP or REO. This will be the anterior apex inferior. Okay. And this is the atrioventricular groove, so this will be the LAD, okay, and this will be the LCX. This is OM, first OM, and this will be the PDA, okay, and this will be dominant. So, why? What's the kissing sign? That all vessels are moving in one direction, okay, and the LAD in the other. If you the OM and PDA or second OM, okay, are moving upward towards the upward, and diagonal is moving upward, okay. Why? The LAD is moving downward, okay. You notice that? The LAD is kissing the OM. Okay, it's the only vessel that's moving in this direction, while the OM and PDA and diagonal are moving in this direction. Okay, OM, we will review rapidly. Dr. Marwan, where is the OM? This or this or this? This. Okay. This. What is this view? REO or LEO? REO. From what's our clues to that's REO? Okay. This is the shaft. So this will be the aorta. So this will be the spine. So direction of the ribs will be in this direction. So you will catch the shaft by putting your right hand, okay? So this is the REO, okay? Once this is the REO, so what's the wall? This view has a parasternal long axis in the echo, okay? So this will be the anterior, apex, inferior, okay? And behind here will be the left atrium, okay? And this is the aorta. So the anterior, what's the vessel supplying the anterior wall? LAD. So this is LAD. What's the vessel going in the atrioventricular sulcus? The LCX. We will return back, okay. This is the coronary anatomy. This vessel, the most anterior vessel, is the pulmonary. Behind it will be the aorta, okay? And this is the SVC, and this is the pulmonary veins draining into the left atrium. This will be the LV, and this is the RV. And between the LV and the RV will be the interventricular sulcus, okay? And this is the RA, and this is the RV. Between the RA and RV, atrium and ventricle, will be the atrioventricular sulcus. So you have two planes, okay? Horizontal plane, okay, or oblique more or less, and perpendicular plane on it, okay. So the horizontal plane, the atrioventricular sulcus, here will anterior will be the RCA and then continue posteriorly, and here will be the LCX and then continue posteriorly, okay. The atrioventricular, the interventricular plane, okay, anteriorly will descend the LAD. From its name is left anterior descending, so it's descending into the interventricular sulcus, and posteriorly is the PDA, posterior descending artery. Okay, this is posterior. This is a continuation of the RCA. This is a continuation of the LCX, and this is the PDA anastomosing with the LAD. Okay, so as we said, this is aorta, this is the shaft, here is the spine, direction of the ribs towards the spine. You can put your right hand, so this is RAO. Okay, once this RAO, this is the angiogram. So this is the anterior wall, apex and inferior. Okay, what's the vessel supplying the anterior wall? It's the LAD. Okay, where here is the atrioventricular sulcus? Here, as a circle. Okay. And this is the interventricular sulcus. So the LCX will be here and the RCA from back. Okay? Continuation with the LCX in the same. Okay? So this is atrioventricular. This is backward, okay? And this is anterior. This is posterior. This is atrioventricular, while this is interventricular. Okay. So this will be the LCX. Okay, and this anterior wall LAD, and this inferior wall will be DA. From the LCX is left dominant, from the RCA right dominant. What? Okay. What's this view? It's LAO. From which we know that's LAO. This is the shaft, so this is the spine, so this is the aorta and the spine, so the ribs will come here. Okay, so you put your left hand to catch the calf. Okay, so it is LAO. LAO, what's the walls? It is a short axis of the heart. What's the short axis of the heart? Of the LV. This is the LV, and this will be the RV here. Okay, and this is SALI, septum anterior lateral inferior of the LV. So what's supplying the septum? LAD. Okay, it passing anterior to the interventricular septum. Okay, interventricular sulcus. And this what's supplying the lateral? LCX. And inferior PDA. If come continuation with the LCX, so it's left dominant. If it's come from the RCA, would be right dominant. Okay, so this is the short axis of the heart. This is the LV. This is the RV. Okay, as a crescent on the LV. Okay, and this is SALI, septum anterior lateral inferior. Septum supplied by the LAD, lateral by the LCX, and this is by the PDA. Okay, again and again and again. This is RAO, so we will expect the spine to be here and the shaft, and this is the walls, anterior, apex, inferior. Okay, so what will supply the anterior? Yes, and where is the atrioventricular groove or AV groove? Here as a circle. Yes, perpendicular to you. Yes, so you will expect here anteriorly to be the LCX from behind, okay, and anterior will be the RCA, okay, on the same plane. Inferior, if coming from the LCX, will be left dominant, from the RCA will be right dominant. This is view what? LAO, okay, so you will know that's LO. You will expect the shaft here, aorta and spine, and the ribs will be directed here, and you can catch the cast with your left hand. So this is SALI, septum anterior lateral inferior. What's supplying the septum? LAD, lateral, LCX inferior, If it's coming from the LCX, so it will be left dominant. From the RCA will be right dominant. Where here will you expect the RV? Here. Okay, as we said, it's a crescent in the short axis of the echo. Short axis of the echo, you see the LV and the RV here. Yes? And this will be the septum between both. Okay? So this is the atrioventricular sulcus, while the interventricular sulcus will, as you said, perpendicular. Okay? Here, on the septum. Okay? This is what we see. Okay? This is RAO. So, because the aorta is here, and the spine and the shaft, okay, and the ribs will be directed in this direction. Okay? So this what? Anterior, what's the wall? This is the anterior wall, inferior, and this, as you said, this is the perpendicular plane on it. Okay? What's the atrioventricular plane? Okay? So the anterior wall will be the LAD, inferior will be the PDA, and the perpendicular plane atrioventricular will be the LCX, and this is the RCA anterior. If the LCX giving the PDA will be left, but in 85% it's come from the RCA, so it is dominant RCA. Okay? What's this view? Left. Where is the aorta? This, in this direction. So the aorta is here, spine is here, shaft is here, direction of ribs will be this, so it is LAO. LAO, so what is this walls of the left ventricle? Sali, septum, anterior, lateral, inferior. Okay, this is the inferior. So septum, what's the supplying the septum? LAD, lateral, LCX, inferior. If a PDA coming from the RCA, right dominant, coming from the LCX, left dominant. Where is the RV here? It is here as a crescent. Okay, and this is the right atrioventricular sulcus containing the RCA. Okay. So know the view, LO or RAO, know the wall. What's this wall? So you will know the artery. Okay, supplying this wall. This is normal dominance. What's this view? Yeah. Yes. Yes. Left. So it is LAO. So what's the walls? Sali of the LV. So it will be the septum here, anterior, lateral, and inferior. And this will be inferior, okay? And this will be the RV, okay? So it is RCA, and it is supplying the inferior of the LV. So it is right dominant, 85%. While here, what's this view? Where is the cast? In the left. Okay, so it's LAO. Okay, it's LAO, and the ribs will come here, and you can catch it. Okay, LAO. So the LAO. So what's the walls? Septum, anterior, lateral, inferior. What's the vessel supplying the septum? LAD. It's the left main dividing into the LAD and come down to supply. Interventricular septum, interventricular plane, yes, and the atrioventricular plane, this. So you will expect the RCA will become here, yes, and this is the lateral wall supplied by the LCX. This is the inferior wall study supplied by the LCX, so it's left dominant 10%. Okay, let's continue. We said it before. This was this view. Dr. Alamis, what's this view? The ribs are directed this, and this is the shaft. So what's this view? Right. Okay, as X-ray. If this is the shaft of the spine and this is the liver, so the liver will be in the right. Okay, so it is right. So it's the right anterior oblique, RAO. Okay, so it is RAO. cranial or caudal. The difference between cranial and caudal is diaphragm. This is the diaphragm, so it's cranial. What's the difference between cranial and caudal? No difference in the walls. It will be the same wall. What's this anterior, apex, and inferior? The difference is, while you are saying the camera is imaging from cranial view, I looking, so I will see the distal vessels, not the proximal. If I see the camera is imaging from the caudal, from below, from the diaphragm, you will see the proximal segments. Okay? This is LAD. Okay? Why? Because this is REO, this is anterior, this is the LAD, this is diagonal, and this is the LCX. And they're not supplying the inferior, so it's not dominant. This is the same REO, this is the shaft, so this is REO caudal, this is anterior wall, so this is LAD, this is the atrioventricular sulcus. Okay, so this is the LCX. Okay, and you can see that the proximal segments are very long, and you can identify it because it's caudal. Okay, while the mid and distal segments are foreshortened. Okay, this is the LO color because this is the shaft, so it's LO, and this is LO, this is the shaft. This here are diaphragm, so it's cranial, Sali, septum, anterior, lateral, inferior. So this, what is this? LAD is this lateral LCX. Okay, not dominant because no inferior. What's this? Shaft is here, spine is here, aorta is here, so it is LAO. Okay, so what is Sali, septum, anterior, lateral, inferior? So the septum, LAD, lateral, LCX, no inferior, so it is not dominant. We stopped here. Which is LAD? Is this vessel, this, or this, or this? Show the move. See the move. Okay. The vessel is this. Why? Yes, anterior. The anterior, as we said, if this is the RV and this is the LV, so this is the interventricular groove. The interventricular groove containing the LAD. Okay? Yes? Anterior and PDA posterior. Okay? So the LAD giving septal perforators, perforate the septum to supply it. And the PDA giving septal perforators. Okay? To supply it. It's a Y-shaped small vessel. Okay? Why? What will supply the anterior wall of the LAD? Diagonals. Okay? So the LAD give diagonals to supply the anterior wall of the LAD and septal perforator to supply the septum. Okay? So diagonals maybe in some cases it's at the same size or more than the LAD itself. Okay? Especially if the LAD is occluded. So this is the diagonals and this is the LAD. Why? Because there is what we say, what we call is kissing sign. What's the kissing sign? The LAD is kissing the all other vessels. Okay? If you see, this is the OM, obtuse marginal, and the PDA are moving in the upward, and even the diagonal is moving upward. Okay? While the PDA, the LAD is moving downward. See it again. Even the diagonal is moving upward. Okay? While the LAD is moving downward. All of them are moving upward. While what's the importance of this sign? If you have a patient with acute coronary syndrome, anterior STEMI, okay, and had a large diagonal, okay, for the first time, if you take one view, REO view, you will say that this LAD, this diagonal and reaching the apex and supplying the anterior wall, and there is no abnormality in this case, okay, while the LAD is totally occluded without stump, so you can't see the LAD, but by this sign you can differentiate. Okay, that there is no vessel casing, okay, or moving in the other direction against the LED and the OMs and CX, so that LED is totally occluded. Look at the movie. What's this view? Yes, this is the spine and this is the ribs, so this is right. REO. REO, cranial or caudal? Cranial. Yes, this is the diaphragm. Okay. So it is REO cranial. And what's this? Yes. REO or LAO? The ribs are directed here. LAO, yes. So it is cranial or caudal? It's LAO, cranial or caudal? Cranial, because this is the diaphragm. This is the PL and PDA. PDA is supplying the inferior. Okay, so it is seri, septum, anterior, lateral, inferior. Okay, while here anterior, apex, inferior. And this is circle of the atrioventricular, and this is the circle of the atrioventricular. Why is the circle of the interventricular is perpendicular to you? Okay, it's clear. As we said, this is what's this view? Left, yes. So left, LAO. Okay, so the LAO cranial or caudal? Cranial. Okay, so this is the diaphragm, so this is cranial, and this is the ribs are directing towards the spine and okay. So what's this? This PL. Okay, to hold anastomosis with the, and this is the inferior wall, so the PDA, and this is seri, septum, anterior, lateral, inferior of the LV. Okay, what's the branches of the RCA? As we said, what's this artery? It's aorta. Okay, this is the aorta. Aorta or not? Aorta is the most anterior. It's a pulmonary. Okay, so it's a pulmonary. The aorta is behind. Okay, so it is the pulmonary, and this is aorta, and this is the SVC, and this is the right atrial appendage. The right atrial appendage, you see what it's taken, okay, by eclipse upward. Okay, so this is the RCA. Okay, giving what? First, giving SA nodal branch, this branch to the SA node. Okay, then come here. Okay, this branch is the conus branch. What's supplying the conus branch? The RVOT, right ventricular outflow tract. Okay, it's a very, very, very arrhythmogenic area. So if during coronary angiogram, if you selectively cannulated the conus branch and giving dye, the patient will go into VTAC or VF at the moment and may arrest. Okay, so it's a very critical. In some cases it has a single, okay, but in most cases it's this is after the SA nodal branch. Okay, so it's the conus branch, maybe the first branch, and then the SA nodal branch. Here the right atrioventricular sulcus, as we said, yes, and the RCA it's going backward. Before it's going backward, he will give the RV branch or the acute marginal branch, okay, anteriorly. So this is the acute marginal or RV branch. What is going posteriorly, okay, will terminate by bifurcation into both PL, posterolateral, and this is the PDA in the posterior interventricular septum. Okay, and the PL will communicate and the anastomosis with what? With the LCX in the left atrioventricular groove from behind. Okay, so as we said, this is the SA nodal branch. The first branch is here is the conus. Okay, going to the RVOT. What's this view? Right. Okay, excellent. This is the spine, this is the ribs, so this is the RAO. Okay, so this is the anterior wall, this is the inferior wall, and this is, as we said before, the atrioventricular groove. Okay, so here will be the LCX, the RCA, and continuation on the other side will be the LCX from the back. Okay, so this is the conus branch. Okay, so what's this vessel? This, the most anterior. This is the pulmonary. This is the aorta. Okay, so this is the pulmonary and this is the aorta. This is the right atrium, this is the RV. Okay, so this is RCA giving acute marginal before going back into the atrioventricular groove. Then in the back bifurcate to two terminal branches, PDA in the posterior interventricular sulcus and the PL. Okay, the PL giving a branch to the AV node. So why patient may go to heart block in about 60% of patients. Okay, and it may come from the LSX in the other patients, but 60% it's come from the PL. Okay, so if the PL it's obstructed, the patient okay will suffer from complete heart block. Okay, it's a very important branch. Okay, the PL giving the AV node, while the SA node come from the RCA as the first. PDA, what's the branches that giving that it give PDA? We said as LAD, septal perforators, perforating the septum from inferior. Okay, anterior, and both on the interventricular sulcus. So what's this view? RAO. Okay, so what's the walls? You will expect anterior, apex, and inferior. Okay, and this is the plane perpendicular to you is the atrioventricular sulcus. So what's this view? Yes, LAO. This is the direction of the ribs. Okay. Yes, diaphragm. It's left cranial. So what's the wall? It's left. We left. So the walls is what? Sally, septum anterior, the circle, the short axis. Septum anterior, lateral, inferior. Okay? So you will expect that the septum will be here, anterior, lateral, and inferior. Okay? So what's this vessel? RCA. Okay. What this vessel will be? SA node in the first. Okay? This is the SA node. But what this? RV marginal, acute marginal. And this acute marginal. Okay? This what? PDA? Yes, and this is the PL. Okay? This is a posterior descending and this is the PL. Okay? What's this view? This is a spine, it's clear? Yes. So it's left. Okay? So it's LAO. Caudal or cranial? Caudal, no diaphragm. Here is the diaphragm. Okay? Here is no diaphragm. So it is caudal. Okay. What's this view? Yes, it is RAO. This is the shaft. This is the spine. So it's RAO. No diaphragmatic shadow, so it is caudal. What is this? This is the shaft in the middle. Okay? And the spine so in the middle. In the middle. If the camera is imaging me.
Okay, left LA.
Imaging me, okay? Where is my aorta? Here. Fine. And the shaft, the caster here. So it's what this AP, anteposterior. It's not RAO or LAO. Okay? Yes. So you will know it from the shaft in the middle, the spine in the middle, and in the when you are imaging the left system, you will see that the shaft is cutting the left main or proximal LAD. Okay? So close PA or AP as you want. This is AP cranial because there is diaphragm, caster and spine in the image in the center. Okay. So what this view is? LAO, yes, because the ribs are here. Cranial or caudal? Cranial. This is diaphragm. Okay, very small, but it's diaphragm. So it's cranial. Okay. So what this vessel is? So what the walls? Sally, septum anterior, lateral, inferior. This is inferior. While this is the continuation of the LCX of the PL to communicate with the LCX. Okay? So this is the PDA. This, and can you see the septal perforators? This is the septal perforator. While this is the SA nodal, the AV nodal branch. Okay? This is small branch. Okay? So this is the PDA and this is the PL. Okay? Where is the lesion here? In the mid RCA. What this vessel? Marginal. And this small marginal. Okay? What this view? This is the direction of the ribs. Yes, it's REO. Okay? So REO, what's the wall? REO, it's as long axis, okay? Anterior, apex, inferior, okay? So, and this is perpendicular to the atrioventricular groove, okay, or sulcus. So this is RCA, okay? This what expect to be this? This is RCA. What's this branch? This may be marginal, yes. Okay. And this is what? SA node. And this, the first going to the RVOT and the pulmonary, just below the pulmonary valve. Conus. Conus. The conus is the RVOT. Okay. The outflow tract is termed conus. All the first branch. So it's the conus and this is the SA nodal branch. Okay. This is the RV. What's this? Giving many septal perforators. It's a PDA. What's this wall? Sally, septum anterior, lateral, inferior. It is inferior, it is right dominant. Okay? And this is the PL. What's this view? Anterior posterior ماشي في النص. Okay, so this AP, okay, or PA. The AP you expect it to be resembling the REO or LEO. What's the position of your heart normally? Yes, it's REO. Okay. This is if you the most anterior chamber. It's RB and the LB is small, okay? So it is the REO, okay? It is resembling shallow REO, okay? If you see from, but you can't see the right atrium or LB, okay? Appropriate. If you, this is the REO, okay? If you come here, so it would be the REO, okay? This is the AP, it resembles REO. So anterior, apex, and inferior, okay? But with lesser degree. While the LEO, you will have a cut section, LAD and RB increasing. It's clear? So as Ismail said, this what? This AP. So what's the walls? Anterior, apex, inferior. And this is the oblique, not perpendicular but oblique to some extent, AV, because here my rest is AV atrioventricular surface, okay? So it will be oblique, okay? Not perpendicular to you. If I am in the RAO, it will be perpendicular. But if I am AP, it's not perpendicular, it is oblique to some extent, okay? So this is inferior, so what is this will be PDA, and this is continuation of the RCA to communicate with the LCX here, okay, will be the PL. There is a critical lesion here and here, okay, in the terminal BL, okay. Here, what's the crux here? The bifurcation here is a bifurcation of BDA and LA and PL, okay. We take RCA alone and LAD alone. We will take both simultaneously. Okay. This said before. What this view? Here is the spine. So what will be? RAO. Yes. So what's the walls? Anterior, apex, inferior. Okay. So what's the vessel? LAD and LCX in the atrioventricular groove, yes, okay, and this is the RCA supplying the inferior, okay. What these vessels? Perforators, septal perforators, and these are the septal perforators from inferior, while supplying the anterior will be the diagonals, okay. So this is the RAO view. What this view? Here is the spine and the shaft, LAOs, yes. So Sally, okay, septum, anterior, left, lateral, inferior, okay. So what's supplying the septum? Yes, LAD, and here will be the septal perforators, okay. Here and here will be diagonals, and here will be septal perforators, okay, but it's all overlap. And here's the LCX. What's this? OM. And what's this? OM. Okay? This is the RCA, the continuation of the atrioventricular groove. While here the atrioventricular groove is perpendicular to you, here the interventricular is the perpendicular to you. What's this view? Here the spine, so what will be? LAO, and here a diaphragm, so what would be? LAO cranial. So Sally, septum, anterior, lateral, inferior, and this is the RCA continuation of the AV groove, okay. What's the difference between the RAO cranial and RAO caudal? LAO cranial and LAO caudal. It's the same wall, septum, anterior, lateral, inferior. But what's the difference? The diaphragm I asked about the distribution or of the vessel. As we said, okay, the caudal you can see the proximal segment, okay, while the cranial we can see the mid and distal, okay. So if can you see my hand here? No, okay, it's for shortened for you, okay. What if can you see it here? Straight, okay. So it is cranial. What if it is caudal? You can see it, okay. So from the caudal, what you can see? The proximal segment, okay. While cranial you can see the mid and distal. clear, Dr. Moran? So this is the first thing to be remembered. The second, the cranial make which vessel become more straightened and more inferior to you, that you can study it well and comment on it. The anterior. Okay, so the cranial will give you the anterior vessel more down, while the caudal you will see the posterior vessel and the spine. Okay, so the cranial will show the mid and distal segment, okay, and the anterior segment, okay, the anterior vessel, while the caudal will show the proximal and the posterior. So if there is an overlap between the LCX and LED, and you want to, and the angle is, as we said, REO 30, 20. What's 30 and what's 20? 30, it is the first angle, it is the angle of right or left of the camera. Okay? The camera can be here 0, so it's AP. Okay? Can be LAO 30, so it will be here. This is 30. Can be here 30, it's REO 30. Okay? So it's REO 0, because not cranial or caudal, it's at the level of the heart. Okay? Or LAO 0, REO 0, or AP 0. Okay? Can after that we make it cranial or caudal. After I move it to the left, LAO, can I move it cranially or caudal as I want? Okay? So the second angle is cranial or caudal. How much the angle is cranial or caudal? Okay? So if it's overlapping the LAD and LCX, and I want to, there is a lesion in the LCX, but there is an overlap and I can see it. You want LCX, you want to increase the caudal or the its caudal view, and it is 30, 20 caudal. Okay? To see the LCX more, what you will do? Increase the caudal. Okay? So once you increase the caudal, the LCX will descend more. Okay? You straighten, descend, and you will can see it. Okay? And the opposite for the cranial, for the LAD. Okay? So here it is the cranial. Okay, you can examine the mid and distal segment. What here is the caudal, you can examine the proximal segment of the LAD and the LCX and left main. Okay? It's clear or not? We said that this is what's the view. It's a normal heart. Okay? It's AP. So it is AP or PA with subpulmonary aorta SVC. Okay, this is the right coronary. Okay, giving marginal. Okay, and then behind dividing PDA and PL. Okay, and here at the bifurcation giving the AV nodal, or after that the AV nodal branch. Here the LAD. Okay, and this is the LCX will come here. So it's, as we said, the anterior as what? REO, anterior apex inferior. Okay, but the AV, it's not perpendicular to you, AV plane, but it's more oblique. Oblique to some extent, not perpendicular, as this. This is REO, it's almost perpendicular. Okay? Okay? What's this view? It's a cut section. So it's LAO. It is LV, Sally, septum, anterior, lateral, inferior, and this is RV as a crescent. And this is the AV groove. Okay? What's this? Left. But what left? It's left lateral. Why we said lateral? Because it's left, as you said, but it is not 30 or 40 left, it is 9. Okay, as the lateral view in the X-ray. Okay, so it's left lateral. You are right, it's left, but left lateral because the angle is 90. Okay. From this view, we can see what? The same. Okay, in the lateral view, you will see anteriorly here. How you will know the lateral view? There here will be a sternum, and here will be the what? The spine. Okay, anterior, and this is the LCX. Okay, this is the RAO as we said, anterior apex inferior, and this is the AV groove. There is right lateral, yes, there is right lateral and the same orientation. Okay, peers to be kept in mind. LSX goes with the II, okay, the image intensifier, which is the camera, and the LED goes in the opposite direction. What does this mean? If the view is LAO, okay, so the spine will be on the left or the right? Left of the patient, okay, here, okay. To LAO was the left of the patient as X-ray, okay. So where be the LCX? With the spine, because the LCX is posterior, more near to the spine, will be more near to the shaft, will be seen more with the caudal. Okay? While the anterior, it will be away. Here will be the spine, so here will be the CX, but the LED will be away from the spine and from the circ and from the shaft. Okay? So as we said here, this is LAO. Okay? So where will be the spine in this view? Here, LAO and here. Yes? So what is the nearest vessel to the spine? LCX. And what's away from it? LAD. Here it's RAO. So where is the spine? Here. So what's the nearest vessel to the spine? Will be the posterior LCX and what's above? Okay? The LAD. Here the spine, LCX and the LAD. Okay? It's clear? It's the same in the lateral. This is the lateral. This is lateral. Which lateral, left or right? It's left lateral. This is aorta. This is the spine. This is the shaft. So what will be here? LCX. Okay? Near to the spine, to the aorta, to the shaft. Okay? And what will be here? LAD. Okay? In the lateral, what's the vessels? OMs above, and the most inferior will be the continuation of the LCX or the PDA. Okay? This is the inferior. Okay? The second thing, cranial angulation pull down any anterior structure as we said. Okay? While caudal angulation pull down any posterior structure. So the caudal angulation, more the caudal, more you pull down the LCX, straighten it, and you can examine it. More the cranial, you can pull down what? The LAD. Okay? LCX is posterior, so it's near the spine, near the shaft of the castor, near the aorta. Okay? We said all of this. Okay? So, what's this view? This is a spine. Quickly. This is RAO, yes. RAO. So, what's the wall? Anterior, apex, inferior. Yes, and this is the AV group. So, anterior, apex, inferior. Okay, so okay, this is not RAO exactly, but it is AP. Why AP? As we said, this is a camera, this is X-ray tube, and this is the camera, and this AP. It is simple to the RAO. Okay, what the spine and the shaft will cut what? The left main or the proximal LAD. Okay, and the walls as RAO, as we said, because it is the normal orientation of our heart. Okay, the more anterior wall is by the RV. Okay, it's simple to the RAO, shallow RAO. So what this will be? This left main, this is the caster, tip of the caster. Okay, and we'll see the shaft. Once it's AP, will cut what? Left main or proximal LAD. Okay, so this is the left main. To what's the vessel? This wall will it is the anterior, it's the LAD, and this is apex inferior, this is LSX, and this is the AV groove. So this is LAD. Okay, this is what this diagonal, and what this septal perforators. Okay, this is LCX, and this what OM. Okay, this what's view? As you said, this overlap here. Okay, once you get what this view, this RAO, right? Okay. Oh, camera is here. Okay. Yes, it's right of the patient. So because this is his head, okay, not his leg. So the camera is on the right side of the patient. What is left main LAD? Okay, LAD. From what's the part of the LAD which is proximal LAD? We say lesion in the proximal LAD. Of what? First diagonal. In some literature, you will read it for the first perforator, but in the most it's first diagonal. Okay, so it's the first diagonal. This is the LAD, proximal LAD. From first to second diagonal, it's the mid LAD. After that, it will be the distal LAD. Okay. While the OM, proximal OM, what? To localize the region. The same. First OM, proximal LAD. Second. First to second mid, and distal it's to the second will be the distal LCX. What's this view? Yes, it's LAO because the spine is here, and you can put your hand this way, and the lips will directly meet, and here will be the shaft and the aorta just in front of the spine. Okay. So it's LO cranial or caudal? Here is the diaphragm. So it's cranial. What's the walls? Sally, septum, anterior, lateral, inferior. Okay. So what's this vessel? LAD, and this LCX. Okay. This is the best view to view the diagonals, wide angle between the LAD and diagonals. Okay, if there is overlap. Okay, this is diagonal, this is diagonal, so this is the proximal LAD, this is mid, and this is second diagonal, this is the distal LAD. And this is the septal perforated. I said to you before, it's Y-shaped small branches perforating into the septum. What's this? OM, yes. OM, and this is X. It is non-dominant because the inferior wall is not supplied by BTU. Okay? What's this view? Here's the spine, so it is LAO. Okay, so it's LAO. It's the head of the patient, LAO 55. Okay, and then this is the tube. After going to the left, it's going the camera. After going to the left, going up. So it's LAO what? Cranial. Okay, so it's LAO cranial. So what's the walls? Sally, septum, anterior, lateral, inferior. So what's this? LAD, yes. And what's this? LCX, and this is septal perforators, and these 5 diagonal. What's this view? This is the spine and this is the sternum. Lateral. LAO, okay? Left lateral. Okay? Not oblique, it is a 90 degree. So it is left lateral. LAO, what's the abbreviation? Left anterior oblique. The camera, it is left and anterior and oblique. But if it is 90 degree, it is left lateral. It is anterior, it's AB, anterior oblique. Okay? RAO, right anterior and oblique. Okay? It's 90 degree, it's right lateral. Okay, when the lateral as X-ray, this is the spine and this is the sternum. So what is the most posterior? SX. And what is the most anterior? LAD. Okay? And this what? Septal peripheral is the Y-shaped and not Y-shaped, this is diagonals. Okay? And this what? 7? OM. This? OM2. And this? Left circ, and this not dominant. If it's dominant, will give you inferior PDA. Okay, what's the proximal LAD? From the ostium to the first diagonal. Yes, from the first diagonal to the second diagonal, it is the mid LAD. From the second to the third, it will be and distally will be the distal. The proximal LCX from the ostium to the what? First OM. From the first OM to the second will be the mid and then will be the rest. What's this view? This is the spine. Yes, so it's LAO. Okay? The LAO is the head of the patient and it is the camera on the left of the head, so it's LAO. Okay? And the spine in here. It is cranial or caudal. The camera is going caudal. Okay, so it is caudal. So there will not be diaphragm. Okay. So what's this vessel? RCA. What's the walls? Sally. مش LAO. Septum here. Sally of the LV. Septum. Anterior, lateral, inferior. Inferior is supplied by the PDA, so it will be dominant. Okay, what's this branch? What? SA? Not SA. Why not SA? This is a conus. Why? It's the first branch is the conus. The first thing. The second. Where here is the RVOT? It's a cut section. It's a cut section. Okay, so where is the RVOT? This is the LV and this is the RV. Where will be the RVOT? Okay, more deep. Okay, so this is the direction. Okay, while in the REO will be the RVOT here. Here will be the aorta and here will be the pulmonary, so here. Okay? It's clear? So this is the conus, and what this will be the SA nodal branch going to the RA more deep. Okay? This is acute margin, acute marginal. Okay, this is the PDA and this is the PL and the AV nodal branch just after the bifurcation. Okay? This is the bifurcation into PDA and PL, and this is the AV nodal branch. What's this? RAO. Yes. RAO, excellent. RAO, okay, there is no caudal or cranial. Okay? It is RCA. What's this branch? Where is the pulmonary? What's the wall? What's the wall first? Anterior, apex, inferior. Okay, and this is the plan of the atrioventricular groove. Yes, here's the aorta. Where is the pulmonary? In front, anteriorly. This is anterior, so pulmonary will be here and the RVO2 will be here. Yes, subpulmonary. The conus is subpulmonary. Okay, so this is the conus 6. Okay, it's clear. while in this the conus where is here. Okay, what's this? SA, yes. Why? Because it's the atrioventricular plane here, and here is the RA and LA, and here's the RV and LV, anterior, apex and inferior. Yes. تمام. To Marwan. Anterior, apex, inferior, it's the ventricles, LV and RV, while behind is the LA and RA. So this is, let's see, no, this marginal, this marginal, this PDA. PDA was perforators Y-shaped. Okay. What's this view? Okay, it's not a common view and no one make it. What's this view? Sternum and the spine. Left lateral, yes. It's left lateral. So what's this plan? Left lateral. So here will be the apex to the spine, to the sternum, and here will be the atrium, okay, towards the spine. So this is the AV groove, yes? So what will this vessel? This is interventricular, perpendicular to the atrioventricular, yes? So this will be the BDA, and you're expecting the LED to come here, yes, to communicate with the BDA. And you're expecting the LCX to become here, yes? So, where is the pulmonary? Here or here? Yes, anterior, or toward the sternum. So this is the conus. Where is the atrium? Backward. So there is the SA nodal branch, and this acute marginal, second marginal, and this is the PDA, and this will be the PL to AV nodal branch, okay, to communicate with the CX, okay? Yeah. What's this view? LAO. Where is the shaft? This is the shaft. This is AP, okay? Crossing the proximal LAD, so this is mostly AP. So AP resembling the RAO. So this is anterior, apex, inferior. Okay, this is the AV nodal groove, and this is here the atrium. Okay? So this is what? LAD, this is diagonal, anterior, okay? And this is vessel what? LCX. This is the left. Okay? LCX. Okay, so what's this? OM. Yes, OM2. Proximal, mid, distal. And no supply to the inferior, so it's not dominant. Okay? So it's cranial or caudal? AP, cranial, because there is a diaphragm. So once it's cranial, you can see what? The mid and distal segment of this CX. Okay? But you can't judge or comment on the proximal segment. They are overlapping and foreshortened. Okay? Here, what's this view? This is? Yes. RAO, cranial or caudal? Cranial. This is the diaphragm, so it's a cranial. So what's the wall? Anterior, apex, inferior, yes. So this is what vessel? This what? Diagonal 1, 2, and 3. If there is small vessels here, will be the perforators. This is what? This is the LCX in the. Can you see it? In the AV groove, okay? And not supplying the. Not the spider. It is cranial. The spider is LAO caudal. This is RAO cranial. Okay? This is the spider view, as you asked, Dr. This is the shaft on the left. Okay, so it's what's this view? LAO, cranial or caudal? Can you see diaphragm? Caudal. So it's a spider view, it's like a spider. LO, what's the wall? Here, septum, anterior, lateral, inferior. This is a spider, Dr. Marwan. Okay, this is the shaft. So there will be the spine, the diaphragm, the spine, the aorta, the shaft. Okay, so this is LO, cranial or caudal. Caudal because there is no diaphragm. So it will be Sally, the wall, septum, okay, anterior, lateral, inferior. Okay, this is the left main bifurcating into the LCX and what? LAD. Yes, this is a caudal, LA caudal. Can you see the LAD? It's very just the ostium of the LAD and the bifurcation. Okay, but what you can see? The circle, because it's caudal, and as we said, once you move caudal, it will descend, pull down the posterior structure with the LCX. Okay, and what's the LCX is near to the shaft, near to the spine. It is the same as the view. It's LO, so it is on the left of the of the patient. Okay, this is our mnemonics. Okay. And this is the LAD, it is rising and go down to supply the septum here. Can you comment on this LAD? No. Okay. Just the ostium or proximal part. No middle, no distal, anything. Okay. This is what vessel? What view? RO, yes, excellent. RO, so this is the spine, okay. And there is no cutting of the left main or proximal LAD to the by the shaft, okay, of the cath. So it's RO. What's the walls? Anterior apex, inferior. It's a huge PDA. Yes. So it is left dominant. Okay. What's this? Left main bifurcate in anterior to the LAD, and this LCX, this OM, and this is PDA, and this is a continuation of the CX to go to anastomose with the RCA, okay, in the AV groove. Okay, this is what? This are the diagonals, okay, large vessels diagonals. This may be this is are the diagonals. The diagonals are overlapping, okay. This is cranial or caudal? This is caudal. So the LCX باين تمام. So it's pulled down and straight, and you can, okay. If it's cranial, this is the RAO cranial. Yes. So RAO cranial, as you see, the LCX is pulled up, while the LAD is pulled down and can differentiate from the diagonals. Here the diagonals are overlapped, and you can see where is the LAD and where is the diagonal. Okay. So this is the RAO caudal. Okay. RAO. So the spine here. So the LCX here. So the aorta here. Okay. So the shaft will be here. Here is RAO also. So the spine here. The LCX here. Okay. Okay. And the aorta here, but it is cranial, so pulling down the aorta and can differentiate. It's the best view, as I said to you, this and this two cranial views to differentiate the LAD from the diagonals. What is view? LAO. Yes, it's LAO. Okay. It's LAO. Cranial or caudal? Cranial. It's a diaphragm. It's a very large diaphragm. It's cranial. Okay. Once it's cranial, you can differentiate it, bifurcate if it's caudal, you will see it as on point, okay, or aligned. But if you to see it, you should see it from cranial view, okay. So it's RAO cranial. Where is the lesion? What's this vessel? What's this branch? It's RAO, okay. So where is the pulmonary and where is the aorta? This is the aorta and this is the pulmonary. So what this will be? Conus, okay. And the SA nodal branch will go where? Back to the atrium, okay. And this marginals and this, what's this, PDA or PL? This PDA, okay. PL going here, okay, to communicate with the LCX. This is inferior. This is RAO, so anterior, apex, inferior, okay, inferior, and this is the AV group, okay. So it's now the proximal. Not this is a kink, not lesion. This is a lesion here. Can you see? It's about 80 to 90%, and this is where? Here, yes, there is a lesion, but maybe kink. So if there is an eccentric lesion or kink, okay, you should take a 90-degree perpendicular view to it to see if it's a lesion or not, or eccentric lesion. And if there is a kink, maybe straightened. When if you go to PCI, the vessel will be straightened and the kink and the tortuosity will go. Okay. See this video. It's a reference from the Midmaster. Okay. This is the image intensifier II or the camera, and this is the tube, and here will be the patient. Okay. The tube will go give X-ray. Okay, and the camera will take the image for the patient. All the views are depending on the camera, so just don't remember this. Okay, just remember the camera. Okay, so this is the patient, this is the C-arm in the case. Okay, it can move here or there, so will be cranial, here cranial, and this caudal. Okay, this caudal towards the leg of the patient, and this will be cranial. Okay, and this can move right and left, RAO or LAO. Okay, so this is cranial or caudal, and this is LAO, and this RAO. Okay, this will be the foot of the patient, so will be LAO, left anterior oblique, till 90 will be what? Lateral, not oblique, it's lateral, it's 90 degrees. Here will be right anterior oblique, till 90 will be lateral, right lateral. Okay, as we said here, this is RAO 30. So the camera will be here on 30 degree from the zero, okay, RAO. And this is LAO 40, this is the camera will be here 40 degree from the AP or midline. This is the cranial and caudal, as we said. This is the camera, this is cranial, and this is the camera, this is caudal. The cranial and the caudal, the RAO and LAO can go to 90 degree, okay, or even more in some cases, okay. But here, the cranial and the caudal, it will be obstructed by, inhibited by the patient face and body. So it is not maximum 50 or more than to a less extent. Okay. So this is II or image intensifier. It is the camera, and this is the X-ray tube. We just look for the above, which is II. Okay. So as we said, LAO 40, cranial 25. So the camera will go 40 to the left. Okay. Then after going to the left, he will move it cranial to the face of the patient towards 25. Okay, it's not moving in oblique manner. It's moving in two ways. First ario, then cranial or caudal. First, okay, LO. First ario or cranial or caudal. Okay. This is the coronary arteries, as we said. Okay. This is the aorta. This is the LCX going into the AV groove. Okay. And this is the interventricular groove. This is an AP view. Okay. Interventricular groove going the LAD and give diagonals. This is diagonal and septal perforators and go to communicate with the PDA, with giving septal perforators. Okay, this is RCA giving acute marginal. Okay, and then going PDA and PL to communicate with the LCX. This is the aorta, cut section of the aorta. There are three cusps, right and left, and the non-coronary. The non-coronary cusp is your landmark. It's toward it, even in the echo. The short axis view, the non-coronary cusp is your landmark. It is just toward the interventricular interatrial septum. Okay, so here will be the interatrial septum. Okay, and this is the right and this is the left. So here posterior and here anterior. Okay, left and right. Right giving the coronary, the right coronary, and the left giving the left main that bifurcate into the LAD, LCX and LAD down. Okay, here what will this branch going towards the atrium? Okay, will be the sinus SA nodal branch and to the other to the conus. Here is the aorta. Okay, giving left main. The left main will give bifurcate into, as we said before, will give LAD and the LCX. Okay, this is the LCX in the AV groove, and this is LAD was the interventricular groove. The LCX giving OM, obtuse marginal here, okay, before going, and this is the RCA. Okay, that bifurcate, this is the acute marginal, and this is bifurcate into the PDA and the PL. This and this in front are the acute margins, first and second. This is the proximal to the acute margin, this is the mid to the second margin, and this is the rest. Okay, this is the PL communicating with the LCX. It's clear, and this is the plane of the interventricular, and this is the plane of the atrioventricular, two perpendicular planes. Here is the coronaries alone, and here he puts the heart. Okay. If you have any question, just ask. Stop me and ask. Here's the coronaries. Okay, small capillaries, and the capillaries will give you microvascular. So this is as epicardial vessels, but there are many thousands of, or even millions of capillaries. Okay, and what we are doing with the coronary angiography is just the epicardial vessels and what we can see it, but the micro circulation and the microcapillaries we can see it. Okay, and there are many trials on it, and no proven medication. We give calcium channel blocker, sometimes decrease the beta blocker or stop it. So this is the final. This is anastomosing. Okay, with two circulation, the interventricular and atrioventricular. Okay. ايه لا برضه functional assessment by the thallium or just only. Okay, this is our oicodal view as we said. So here will be the spine, this is the left main. Okay, and there will no diaphragm. Okay, so this is the left main. You will expect the walls here. What's the wall here? REO, anterior, apex, inferior. Okay, so this is bifurcate into a LED, proximal LED to the first diag. Okay, then this is the first diagonal just before it's the proximal LED. This is the second diagonal just before it's the mid, and this is the distal. This is diagonals, and this is the septal perforators. Okay, the proximal contains the first septal perforator. This is the CX. This is first to the first OM. Okay, second OM, and this is the continuation of LCX, and they may give a PDA supplying the inferior. It's not dominant here. Okay, it's in 10%. Okay, this is our caudal view. Can see the ostium of the left main and comment on it. Okay, and the once it's caudal, so you can, and the distal of the left main, you can comment on the left main and the proximal segments. And what else you can comment? It's caudal, so you can comment on the LCX axis. Okay, so you can comment. This view is good for both the left main, proximal, LED and LCX, and the LCX because it's caudal. This is all LA caudal view, which is the spider view. You will see the left main here. Okay, here. Okay, will bifurcate into LED that will go and descend here, and the LCX that will go here. The walls is sali, septum, anterior, lateral, and inferior. So this is the LED proximal to the first diag, mid, and distal. So you can comment very well on the left main to the on the proximal LED and to and the proximal LCX. And this is the first views that are taken for engagement. Okay, this or the RAO caudal, as we say a lot, for the if you have difficult cannulation to pass the wire through the LCX and or the LED. So it's this a very wide angle, and you can differentiate between both and cannulate the LED and the LCX. Okay, as we said. Okay, this is the LCX will be. Okay, this is the OM, and this is second OM, and the LCX will continue here, and if it's dominant will give PDA here to supply the inferior. Okay, post test. Take your paper. ما أخذت أنت بريكس. أنت تقول بريكس مع بعض بس أنت مو بريك خلاص. بريكس كلهم. أنت ما أخذتي؟ لمن لا أخذت؟ هم نفس. Okay. You will A, B, or C. What's the view? And you will comment on the downward vessel. Okay, what's the vessel in the down of the screen? Okay, on the bottom of the screen. Where is it? Okay. And what's the vessel at the bottom of the screen? Last time. Okay. This is the last question. Okay. Okay. Repeat to the last time. What's the view and what's the vessel in the bottom of the screen? Okay. Put the same answer as the pre. عشان انت ما عملتش pre اسمه. Not the same answer at all. Okay. Let's revise and answer them. What's this view? Yes, it's REO. Perfect. Why? Ribs. Okay. The ribs are the equal. So you will catch the calf with your. Okay. So it's REO. Okay. REO. What's the what's the wall? What's the wall? Anterior. Inferior. Okay. And there is the back with the atrioventricular. Okay. So anterior, apex, and inferior. So the vessel is at the bottom of the screen. What's this? What? اللي تحت خالص ليفت سيركل اللي هنا او ام. ماشي الاثنين صح. ماشي يعني اللي مكمل هنا كونتينيويشن عشان يروح ورا على راسي السيرك وهنا الايه؟ اوكي. هذا سيرك continuation at first OM, second OM, okay, and that continuation لل continuation للست عشان يعمل ايه؟ يعمل التونس مع الار سي، okay، عشان ده الاي في بوش، okay, and this is the LAD diagonal, and this is perforators, very large perforators with Y shape, okay. Oh, this is the main bypass. Okay, and this is good for cannulation. Okay, if it's difficult here and go to the wrong pathway, you can go to the LA caudal. Okay, this is REO cranial because there is diaphragm. Okay. What's this? This AP, excellent. Resembling REO because the shaft crossing what? So why this is the shaft? So this is the aorta, this is the spine. Okay, crossing the proximal LAD or left main. So it's crossing it, so it is and resembling the REO. So what's the word? Cranial or caudal? Cranial. This is diaphragm. What's this cranial? So what's the lower vessel will be? LAD is anterior vessel, okay? So I ask about what's the lower vessel, okay? It's a more straightened. While in the previous, it was REO. The previous was REO, okay? So this is REO, okay, and this AP resembling the REO, so the walls will be anterior, apex, inferior. And where is the LCX? You can comment on the LCX? No. Okay, it's overlap. Okay, this is the LED, this is diagonals. Okay, and this is the LCX. Okay, when this is caudal or even REO alone or AP alone, the LCX will pulled down. Okay, so you can see it straight and with the ONs. Okay, so this is none of the above. Okay. Okay, so it is AP. Okay, it resembling REO, shallow REO. تمام تمشي REO. Okay. So what's this? What's the view? LAO. Okay. Cranial. Okay, so what's the wall? Sally, septum, anterior, lateral, inferior. And this is the every group. Okay, so what's this? It is RCA. What's this branch? اس نوت صح رايح لل right atrium. While the conus will be here. Okay, تمام. And this is a total RCA. Okay, acute coronary syndrome was total RCA. Okay, and this is every group. It's clear? So this is LAO cranial of the RCA. Any question? Thanks.